One case will be presented by Dr. Chittaranjan, Professor Chittaranjan, and the second one will be presented by Dr. Abul Hayat Manik. So I'd like to thank all the panelists and all the attendees to attend this session. Hopefully, we'll have an excellent discussion after these two cases, and we'll hear from the expert. So without any further ado, I'd like to start with Professor Chittaranjan Dotto. He will present a case.
Dr. Malik, yes, I just wanted to tell that our PHA, another faculty, Dr. Khurshid Muzumdar from Ohio also is here.
Oh, sorry. Okay. Thank you for, yes. Mm-hmm.
And also Professor Dr. Shahinul Alam, my classmate from Chittagong Medical College, is also here. It's a nice surprise, but he's very much involved with the research, publications, and a great academic guy from BSMMU. Thank you, Shaheen, to join this conference.
Thank you, Shaheen Bhai and Professor Dr. for joining this.
Thank you.
Thank you. Screen share. শুরু করবো নাকি সব স্ক্রিন শেয়ারটা একটু অ্যালাউ করা লাগবে বাস
স্যার আচ্ছা আপনি অ্যাক্সেস দেওয়া হয়েছে কাইন্ডলি একটু চেক করুন
আমি মাল্টিপল পারসনকে স্ক্রিন শেয়ার দিয়েছি আপনি
Thank you all for arranging such a beautiful presentation. My case will be presented by our CSB resident student, Dr. Imran.
Pinch out for.
Assalamu alaikum, honorable teachers. Thanks to all. On behalf of Professor Dr. Chittaranjan Devnath sir, I want to praise our team.
Can do a slideshow. There is a button slideshow you can do if you want. That's fine. Oh, here you go. Okay.
Our patient, Mohammad Abdul Jabbar, 65 years old male, farmer, hailing from Parangan, Mymensingh, admitted in our ward on 22 January 2023. Visiting complaint, upper abdominal lump for 3 months, upper abdominal pain for 1 month. History of presenting inlet, feeling of upper abdominal lump for 3 months, which was gradually increases in size, associated with abdominal fullness, not associated with nausea, vomiting, and alternation of bowel habit. Abdominal pain in epigastric region for 1 month, which was insidious onset, constant dilating in nature, no radiation, more on deep inspiration, relieving by taking analgesic. He also complains of significant weight loss for last 3 months, which was unintentional and not documented, evident by loosening his clothes, associated with loss of appetite, lethargy, and fatigue, not associated with polyuria, polydipsia, palpitation, heat intolerance, and excessive sweating. On query, he did not give any history of night sweat, jaundice, abdominal distension, vomiting or coughing out of blood, passage of black tarry stool, altered level of consciousness, parectal bleeding, and any nodular swelling of body. There is also no history of blood transfusion, surgery, needle shedding, sexual promiscuity, chronic alcohol consumption, close contact with drugs, and previous tuberculosis or contact with pulmonary tuberculosis patient. Past history, he had no significant medical illness like diabetes mellitus, hypertension, chronic liver disease, polycystic kidney disease. Nothing significant drug and allergic history. He is non-smoker and non-alcoholic. He is married. All his family members are enjoying good health. No history of cancer and liver disease in his entire family. He comes from a lower middle class family. He is immunized as per EPI schedule and completed 3 doses of COVID vaccine, but not vaccinated against hepatitis B virus. General examination, patient is well alert, cooperative, appearance ill looking, body will cachectic, nutrition below average, mild anemia, jaundice, cyanosis, clubbing, colonychial, leukonychia, edema, dehydration is absent, pulse 84 per minute, blood pressure 120 by 70 mm mercury, no postural drop present, respiratory rate 80 beats per minute, temperature 99 degree Fahrenheit, no peripheral lymphadenopathy, thyroid gland not enlarged, GBP not raised, other segment of CLD, flapping tremor, and bony tenderness absent, body hair distribution was normal. Alimentary system examination, mouth and oral cavity normal. Per abdominal examination, on inspection, abdomen is distended in epigastric and right hypochondriac region. Flanks are not full. Umbilicus is centrally placed and inverted. No superficial engot veins, visible peristalsis, and pulsation is seen. No scar mark, stria, and sketch mark is present. Hernial orifice is intact. Alimentary system examination, palpation, liver is enlarged 9 cm from xiphoid process and 5 cm from right costal margin. Ill-defined irregular surface, tender, firm to hard in consistency. Upper border of liver dullness is present in right fifth intercostal space. No hepatic B is present. Gallbladder and spleen is not palpable. Kidney is not palatable. No palpable abdominal lymph node. Test is normal and sensitive. DRE reveals no abnormality. On percussion, normal tympanic percussion note, asset is absent as evident by negative shifting dullness. On auscultation, bowel sound is present. Examination of other system reveals no abnormality. On investigation, CBC, hemoglobin 10.2 gram per DL, ESR 110 millimeter in hour. Other reveals within normal limit. Liver function test, bilirubin 2.3 milligram per DL, SGPT, SGOT, LP slightly raised, serum albumin 3.2 gram per DL, INR 1.26. Renal function test within normal limit. Viral markers, HbFAG, NTHB total, NTHCB, all are negative. Other functional, other biochemical tests, fasting blood sugar 2 hours after breakfast, HbA1c, and serum T6 within normal limit. Ultrasound of upper abdomen shows pedoplastic echogenic mass about 8.3 into 7.6 centimeter in left lobe. No asset is present. Common neoplastic mass in liver. Tumor marker alpha fetoprotein 195 nanogram per ml, CA99 and CEA within normal limit. Other tests, X-ray, PAVO, endoscopy of upper GIT, colonoscopy, and hydrogen profile normal. Then we do FNAC. FNAC from liver lesions show malignant tumor of liver compatible with well-differentiated infiltrating hepatocellular carcinoma. So it's our finding and investigation finding. So what may be the diagnosis and further investigation we can do and next plan of management. This is our question.
Okay, thank you. I don't know, would you like to go to the next case, or you want to discuss this case and then go to the next case? I think we can do the two case back to back, since mostly it'll be liver cancer anyway. So, and then we can go to the discussion and we'll come back to the case base. We'll start with the first case and then we'll go to the next case. So I'll invite Dr. Manik, if you can present your case, and then we'll have further discussion. Thank you for your presentation, and it's of course usual interesting case of liver cancer. So next case will be presented by Dr. Manik.
So I can start my presentation.
Pinch out my.
Will I start the presentation?
Yes, you can.
Welcome all our today's presentation. Our tonight presentation is a patient with upper abdominal pain and weight loss. I am Dr. Abul Hayat Manik, working as a registrar in hepatology department, Dhaka Medical College Hospital. Our patient, Mr. Mujibur, 55 years old, male businessman, hailing from Norsingdi, non-diabetic, normotensive, occasional alcoholic, presented to us with upper abdominal pain for 1.5 months and loss of appetite for same duration. His abdominal pain was generalized and dull aching in nature, mild to moderate in intensity without any radiation, abdominal distension, vomiting, or lung. The pain had no relation with food intake and there is no aggravating or relieving factor. Patient also experienced anorexia during this illness period. He had lost significant weight over these 1.5 months, which is not documented, but evidence by loosening of clothes. He has no family history of liver disease. He is a smoker and occasional alcoholic for 10 years. He has history of several times unprotected sexual exposure. He denied any history of fever, cough, chest pain, alteration of bowel habit, tenesmus or rectal bleeding, hematemesis, melena, jaundice, loss of consciousness, history of surgery, and blood transfusion. So on examination, he is ill-looking and he is mildly anemic. Other findings of general examination looks normal. Hemodynamically, he was stable. There was no stigmata of chronic liver diseases. On abdominal examination, liver is palpable, which is 4 cm from right costal margin, mildly tender, hard in consistency with nodular surface. Upper border of liver dullness is in 5th intercostal space. Spleen is enlarged 3 cm along its long axis. There is no ascites, testis looks normal, and other systemic examination reveals no abnormality. So our diagnosis was hepatocellular carcinoma on the background of chronic liver disease. We have 2 differentials also, that is secondaries in liver and alcoholic liver disease. So we go for investigation. Here complete blood count shows hemoglobin was satisfactory 17.1 gram per DL, hematocrit, WBC, platelet, all are normal. Liver function test reveals SGBT 55 unit per liter, albumin, prothrombin time was normal, bilirubin is mildly raised, that is 1.5 milligram per DL. Renal function test reveals serum creatinine 0.9 milligram per DL, electrolytes looks normal. Viral marker shows hepatitis B virus was positive and DNA was 194,258 copies per annum. Very high DNA. Ultrasonogram of whole abdomen reveals mild hepatomegaly, coarse parenchyma with hepatic SOL, polylithiasis, splenomegaly, and bilateral renal cyst was present. Tumor marker, 2 tumor marker was done, that is alpha fetoprotein and CA 19.9, both were normal. Endoscopy of upper GIT done, which reveals esophageal varix grade 1 and portal hypertensive gastropathy severe. Then we have done the triphagic CT scan, which shows liver is enlarged in size. A large ill-defined hypodense mass lesion measuring 19 into 14 into 9 centimeter is noted in the right lobe of liver involving segment 5 to 8. And after IV contrast, heterogeneous enhancement is noted at arterial phase and washout seen at delayed phase. So the impression of CT was hepatocellular carcinoma on the background of CLD, splenomegaly, cholelithiasis, and bilateral renal continuous cyst. This is the CT scan in arterial phase. Here contrast uptake is shown, and later this is non-contrast where hepatic SOL is shown at 5, 6, and 7 segment. We have done FNAC from hepatic SOL because our tumor marker looks normal. Alpha beta protein was normal, so we have done the FNAC from hepatic SOL, which revealed hepatocellular carcinoma. And then we have done the duplex study of portal vein and inferior vena cava, which shows chronic parenchymal liver disease with a large HCC in right lobe. There is portal vein is dilated, but no thrombus was there. Interestingly, there was also no ascites. This is a picture of duplex study sonogram. Then we have done the CT scan of hepatic angiogram. Here it shows large heterogeneous mass lesion involving almost all segments of right lobe of liver, measuring about 13 into 11 centimeter. The main feeding artery of the mass are branches of right hepatic artery and gastroduodenal artery. We have done the CT hepatic angiogram, and this is done for the management purpose. Here we have seen that there is no amputation, distortion, or displacement of the hepatic artery. This is the picture of CT hepatic angiogram. So our final diagnosis was hepatocellular carcinoma with background of CLD, chronic liver disease. Then we have treatment modalities for HCC, which shows we have surgery, local ablative therapy, transarterial therapy, systemic therapy, and supportive therapy. According to staging, according to BCLC, our patient was in intermediate stage. So our plan of management was, patient was in child PAG score A, male score was 16, BCLC staging was intermediate stage. So we choice of modality of treatment, we plan that is test, transarterial chemoembolization. Test was done in last 14 on 2020. Oh, this is a mistake. This is not on 14. This will be 10/10/2023 at Dhaka Medical College Hospital. We have done the test through right femoral approach using the femoral sheath. Slip tip cannulation of right hepatic artery was done using the microcatheter. Tumor was ablated using doxorubicin and lupoidal. Then embolization done with PBA particle 300 microgram. Hemostasis ensured, no immediate complication was seen. This is the cannulation of hepatic artery picture during test. This is the procedure in our cath lab. We have two panelists here, Dr. Fazal Karim and Professor Farooq Ahmed sir. This is the picture of post-test where the tumor shows almost embolization. This is the whole team for test. Our outcome from test, test has been reported to achieve there is objective response in 16 to 61% of HCC patient, and it delays significantly tumor progression and vascular invasion. So in a nutshell, this improved the survival. So this is all about my case. Thank you, sir. Thanks all for patient hearing.
Thank you. Thank you, Dr. Manik, for a nice presentation, including the management. So before I go to all the panelists about those two cases, so one thing is common that both patients really came in with beyond early stage, like, their tumor was really large. And that again raised a question or, the point about this month session about liver cancer awareness. So what is about is to increase awareness, in the general population. I was actually looking at some data about, from Bangladeshi perspective, and there was a data from 2018. It showed that, third common cause of cancer in Bangladesh actually is liver cancer after lung and stomach. But if you look at globally, which is the sixth most common cause of cancer, so it's much more common, and there's increasing prevalence. And the data suggests that by 2040, so the incidence will go up. The number of patients with liver cancer go up by 55%. So according to 2020 data, there are about 900,000 liver cancer being diagnosed in 2020. And out of those 900,000, 830,000 actually died from liver cancers, which means that most of the patient diagnosed, pretty advanced stage, and usually there is no curative treatment options available for this patient. So that is why it's so important to increase the awareness who should get screened for, and especially high-risk patients from Bangladeshi perspective, like hepatitis B, fatty liver patient. And there is one other cancer which is not a primary hepatocellular cancer, but it's cholangiocarcinoma. Actually, few of my relative was diagnosed. So this is from aflatoxin, which is a toxin coming from mold, from the contaminated food products, and spices, because of the humid and warm climate. So patients who have hepatitis B, which is the most common cause of chronic liver disease in Bangladesh, how we can increase the awareness, because hepatitis B is usually a silent disease. So most patients usually don't come to the physician to get treatment or to get checked, make sure they're okay. So those kind of thing, I think, very important. And that is why the awareness month is so important to educate the people of everywhere and globally. They should, even though they feel okay, they feel fine, they should get checked. And the second common one is fatty liver, which is also increasing in Bangladesh as well. A lot of patients may have significant fibrosis, advanced fibrosis, and their liver test may look completely normal, but they should get screened for it. So anyway, so that was the main reason for the awareness. And I'm sure the physicians in Bangladesh, they're working hard. The Bangladeshi government, I know there is a vaccination program in Bangladesh, like a intranasal vaccine for hepatitis B, that is being tried to get implemented widely. And I'm sure every patient who comes to see a physician, they get checked for fatty liver and get checked for whether they have advanced fibrosis like stage 3 or stage 4, and then should get screened for it. So I will start with the so the both cases seems like an intermediate stage. The first patient, as far as I remember, doesn't have anything on the laboratory or any imaging study suggesting any evidence of clinically significant portal hypertension. Patient may have cirrhosis. So the second patient does have clinically significant portal hypertension, eventually underwent TACE. So I'll start with and on these two topics, actually, Dr. Rabbi is here, who does a lot of resection. So we will also hear from him, about these two patients, what his opinion about these two cases. So I'll start with Professor Selimur Rahman Sir. Sir, if you can give your input and about these two cases, or overall liver cancer and your perspective on liver cancer awareness.
Thank you very much, Dr. Ashraf Mali, and many thanks for all of you for organizing such an international webinar across the continent. This is the Liver Cancer Awareness Month. So this seminar is very important to aware the physician as well as the population about the deadly disease. As we have already mentioned, that the prevalence of the disease in Bangladesh among the cancer, it is the 3rd, and in the world it is the 6th. So we should be more careful, we should be more vigilant. And we have seen in both the cases, one is from Mymensingh, led by Professor Chittaranjan Debnath, and another from Dhaka, from the unit of Professor Farooq Ahmed, and presented by Dr. Manik. Both the cases are hepatocellular carcinoma, and they are advanced cases. And in the Mymensingh, they have also diagnosed the case very nicely from their perspective. And we have seen that all these cases are diagnosed very late, and we have no capability to offer the patient a curative treatment. We have given both of them, we could not give a curative treatment, especially the second one, they have also mentioned about the treatment. The first one is also, I think, curative treatment is not possible. So in this month, we should be more vigilant, and we should be more careful about not to miss the hepatocellular carcinoma, especially the patient who are HbA1c positive or NTSB positive or suffering from other chronic liver disease. Because if you follow the cases, if you screening the patient every 3 to 6 months, then you can make the diagnosis earlier and you can offer the best treatment. So I think all of us should be more careful, including the physician and the doctors, especially in this awareness month of liver cancer. And thank you all for arranging such a nice seminar. And thank you, all of you, for inviting me to be present in this seminar. Thank you.
Thank you, sir. Thank you very much for your expert opinion and valuable opinion. I will go to next to Professor Chittaranjan Devnath because he has put us some questions for us. So I'll go to him, and we'd like to hear from him that what treatment the patient received and how the patient is doing, and then of course hear his perspective on the liver cancer awareness.
Thank you, sir. After our diagnosis, we sent this patient to Dhaka Higher Center to Professor Selim Rahman sir for his better advice. And after getting advice, the patient come back to Mymensingh, and we give him lenvatinib 8 milligram for 8 months, but his condition is not improving. Our main problem is that patient when come to us, they come with big tumor and we have nothing to curative treatment. So we give them palliative treatment most of the cases. And in this case, we give lenvatinib for 8 months. But his condition is not improving, rather than his alpha fetoprotein is increasing and liver size, tumor size is also increasing. This is the scenario of the patient.
Okay, thank you, Professor Chittaranjan. So questions are because the second case, Professor Farooq Ahmed, and his team did the transarterial chemoembolization in Mymensingh. Do you have a treatment facility at the Mymensingh, or they have to come to Dhaka to get this kind of treatment?
1 month back at Mymensingh, we had started cath lab. So I hope that we can start test treatment in Mymensingh in the near future.
Okay, thank you, sir. The next one would be Professor Farooq Ahmed. So I'd like to hear his opinion. So the patient, did get the transarterial chemoembolization because it was appropriate treatment for this patient, and so I'd like to hear from him how the patient is doing, and also his opinion about the Liver Cancer Awareness Month and and future vision, because I know you're all part of the Bangladesh Liver Cancer Society, so I'm sure you have a plan or making some plan about future, what are the future steps to improve awareness in Bangladesh, the population as well as physician.
Thank you, Dr. Ashram Malik. I think we have discussed about 2 cases of very common presentations among our population. You know that due to a bit lack of patients awareness, and also in part of our side, sometimes we do not put the patient in some sorts of, in fact, some fear should be put that if they doesn't come in regular follow-up, there is every chance of developing liver cancer, especially in Hep B or Hep C positive patients. So in the first case, if I emphasize some, if in the first case, the diagnostic workup was done after the patient was referred to Dhaka. So possibly there was some sorts of portal vein thrombus or anything like that, for what the TACE or any other treatment modalities, and the size of the tumor was more than 10 cm. So I think the patient was not fit for any sorts of loco-regional treatments. like TACE or RFA. But I think we offered him for immunotherapy, but you know that due to the cost, most of the patients are in fact cannot take the treatment like immunotherapy, which could be the option for these patients, as I think the rest of the liver function reserve volume was a bit better in patient possibly in childbirth A or in early childbirth B, maybe in the first case. In the second case, also you see that the size of the tumor is huge. So it's beyond of any surgical management or liver transplant. So in fact, TACE was not, I think, if we see the indications, maybe TACE was a bit beyond, I think. But the patient was very eagerly seeking us for any interventional treatment for him. And that was and he was, their attendants are also very much eagerly trying to convince us that to do something. But we did the things that we offered him for immunotherapy, but this patient was not ready for this. So we underwent TACE and the patient is a bit improving still. For the next day, there was a bit pain in the right upper abdominal pain, you know. So otherwise the patient is doing well still now. And we'll keep him in further follow-up. So if possible, then we'll offer him the immunotherapy or other treatment later on, not now. So what Dr. Ashraf has emphasized that the main problem is that the first case was non-benign C and the second case was Hep B positive. So in fact, the second case, we could prevent the liver cancer if the patient was put in regular treatment or if early treatment and surveillance was ensured. So we have to keep in mind that we are trying to disseminate the awareness program from the Dhaka to the other cities and in periphery. So in every district, there are hepatologists, almost every district, not all districts, and they are doing well, and they are trying to disseminate the informations to the general populations. But the awareness program, what is running in right now in our country, is not adequate. So there is in government and non-government level, we should have some collaborations, and I think we'll be able to make our people's because already Hep B vaccines are available through EPI schedule, and this is a very good program. You know that our government has ensured Hep B vaccination for in grassroots level and in peripheries also. So Hep B will be eliminated in 2030. We are not much confident within 30, but we will achieve a major targets, I think, before that. So we hope in near future we'll be able to aware our patients to aware about liver cancers and the preventive measures especially. And the mode of treatment right now, other than liver transplants, all other mode of treatment, you know, Dr. Hashim Rabbi and other surgeons are doing really great things. And if we see the follow-up of the patients who underwent hepatic resections, they're doing well. Several patients I have already seen that after large tumor resections also done, and they are doing well. So I think in near future, we'll be able to do liver transplants also, and these modalities will come to the general populations as well. So thank you all for joining today's webinar. And I hope that Paltry Academia will continue this type of program to disseminate their knowledges to us and to enlighten us in near future. Thank you all. Assalamu alaikum.
Assalamu alaikum. Thank you, Professor Farooq Ahmed, for your valuable opinion. You made some important points about the cost and everything, which is really important from Bangladeshi perspective. And then we can talk about it later if we have time at the end of the session. So next I'll go to Associate Professor Fazil Karim. If you can give us some opinion about those two cases, I would like to hear from you.
Thank you very much for asking me to highlight these cases. As you know that liver cancer is diagnosed very late in Bangladesh. I don't know whatever is done in Western world, but in the other countries we fail. Why we fail? We don't know, because we are EPS is covering much of the population. I think we will overcome this in near future. In two cases, one thing is striking: the alpha-fetoprotein is not so much raised. So in our first case, 195, and second case, it is only 37. So this highlights that this is not the only marker. We should look for other markers also, PIPCA2, that should be made available for diagnosis. And second case is that how much is treatment options. These treatment options should be made available, like the advanced treatment available test that is done in Dhaka Medical College. This should be also available in other centers, so that in difficulty phase 2, most of the cases who comes in difficulty phase 2, we can give some treatment. Also, I like to know from Dr. Rabli sir, can we do some rhodium reduction surgery in cancer? This is all from me.
Okay, thank you, Associate Professor Fazal Karim, for your valuable opinion. And next, I'll go to Associate Professor Hashim Rabbi, who is a excellent hepatobiliary surgeon working at Bardem Hospital. Hashim, my choto bhai, so I would like to hear from you about these two cases, and I know you do a lot of resection on liver cancer patients. So, would like to hear from you what is your opinion, and what's your cutoff for resection or any other imaging criteria that you consider for resection versus other treatments such as TACE or ablation, or patients go to systemic therapy like immunotherapy or chemotherapy. So Hashim, please.
Thank you very much. Assalamu alaikum, and welcome to this session again on behalf of me, and thank you for inviting me in this session. So I will start highlighting a few important points that earlier my other panelists also have mentioned, that it's a very big challenge, because most of the patients used to come to us very late. When they come, these are mostly beyond the scope of resection. The hepatology is the specialized subject. It was actually introduced by Professor Mubin Khan sir, Professor Salim Rahman sir, and they are the mainly pioneers of hepatology in our country. And their descendants have started doing a lot of advanced work. We have seen that which were not earlier available to, service was actually not earlier available to each and every corner of the country. But under the guidance of Professor Salim Rahman sir and his team and others, they have contributed a lot in making these services available to each and every corner of the country. So the most important thing, earlier that we have discussed a few of our cases with you and Atik Bhai, that most of the services related to liver cancer treatment is not available in our country. Only liver resection. Nowadays, with the bold attempt of Professor Farooq Ahmed and Dr. Professor Fazal Karim Bhai, and they have started this amazing service with few centers that now the TACE is available. But these kind of patients, when they come late, the available options are immunotherapy, and TARE is the better option. That Y90 is not available in our country. So these are the better options. But we go actually beyond the boundary, because most of the patient doesn't report to us within the Milan. We have to go for beyond Milan. And when we go to manage this kind of patient, these are also beyond the extended criteria. So something needs to be done for this patient. So we usually assess this patient regarding the liver function and the tumor extension. So we do total liver volume, functional liver remnant, and quality of the other future remnant functions, functioning liver. After assessing all those things, we usually decide. So if it is a unilateral disease and the remnant liver is okay and without any portal vein thrombosis or any IVC or hepatic venous involvement, we usually prefer to go for resection if there is no signs of CLD. But the thing is that when there is difficult to make this kind of decision, tumor board is actually essential, because we actually don't know who is doing what. But recently, there's Dr. Fazal Karim and Dr. Professor Farooq Ahmed have started doing a lot of difficult cases. We have seen that we can do combinedly a lot of good things to these kind of patients, because we have to actually push our boundary a bit in the difficult stage. So I think this kind of cases should be managed by tumor boards and make the decisions, not that the patient is coming to me and I'll make the decision to go for resection or other disciplines accordingly. So I think we should work together and work for a state-of-the-art center to make this all kind of services should be available under the single umbrella. I think this would be a very good step, combining all the disciplines to do kind of managing this kind of patients.
Thank you, Hashim. You made, there are several important points you made. You pointed out Professor Salimur Rahman sir, and then Professor Farooq, Professor Fazal Karim. You made the point which you mentioned is about the tumor board or multidisciplinary care. It's very important for liver cancer.
Very
care.
important, yeah.
There's no question about it. The radiologist, the surgeon, the hepatologist, everybody. You kind of come up with the best decision, treatment decision for the patient, especially when there is like a limitation or shortcoming of several things, right? So there's a cost issue. There's a issue with what treatment patient wants to take, and all that. So those are very good important point, and making this session also is going to help in the future. Kind of making these kind of plan about making a tumor board or multidisciplinary care. So I think this is very good.
Another important thing I want to mention here, there is a very scarcity of good interventional radiologists in our country, and the most of the cases, because we have started managing good number of post-transplant patients nowadays. We have seen good number of patients coming to us after transplant with portal vein thrombosis. So these are very much challenging cases. We have also, there are some post-transplant patient came to us with features of intestinal obstruction. We thought earlier that these are the cases of simple gastroenteritis, but later after evaluation, we found that these are the cases of post-transplant lymphoproliferative disorders.
Right,
and later ended up with perforation. We had to manage these kind of patients nowadays. So I think the good number of patients are there, actually huge number of patients are there. And nowadays, good number of hepatologists and surgeons are also coming up in this field. I think we'll be able to start state-of-the-art centers in our country, parallel to the government sectors.
Oh, that's great. That's good to hear. Because interventional hepatology is a field that's not like, as you know, in Western, Western countries, it's not something we do. It's interventional radiology who does. But thanks to all the hepatologists, they have been doing it. That's really, a wonderful thing that patients are getting the service from hepatology as an interventional hepatology. So, like Professor Farooq and Salimur Rahman sir and Chittaranjan Devnath, Professor Fazal Karim. So it's good to hear. Our next panelist, I'll go to my friend. We did the medical school together. He's a radiologist. So I'd like to hear from Dr. Moinul Hussain, because, radiology is a very important part of diagnosis of HCC or hepatocellular carcinoma. I know it's biopsy is being done in Bangladesh because of the limitation in the radiology and everything, but but radiology does make a important role in diagnosing this hepatocellular carcinoma. So Dr. Moin Hussain would like to hear from me about the radiologic perspective of hepatocellular carcinoma.
Your mic is
স্যার আপনি মিউট হয়ে আছেন
muted.
স্যার আপনি
Microphone
Please
is mute.
unmute your mic.
Wait.
Please unmute your mic.
Moin.
Yes.
Here you go. Yes, thank you.
Okay. Thank you, Dr. Ashim Malik, my friend, for giving me the opportunity and give me the opportunity to be the panelist here. And nowadays, for management of HCC, multidisciplinary approach and multidisciplinary expertise are very much useful and necessary. I think it's must like that. So what we face in our country, Dr. Hashim Rabbi already mentioned that we have limitations, a number of interventional radiologists, but our hepatologists, they are doing that thing and they are coming up. And I hope that in future, interventional radiology will definitely come up because that is the normal trend in the Western world. And about HCC, what we face in our country, I'm talking from the perspective of Bangladesh, that in the district towns, we have in the hospitals, we have city facility, but mostly in the rural area, still we don't have that facility. So what we can do, the patients, whenever they're suspicious for any liver disease or fatty liver or suspicion for any liver as well, they should go for ultrasound. I think the ultrasound is inexpensive and easy modality and less expensive, and that can be available in even the rural areas as well. So after they're diagnosed with any SOL, they can, they're referred to the higher center, and they can go for, the CT scan. A CT scan is the choice of mortality, but nowadays even MR is equally, helpful for for the diagnosis of HCC. For HCC patients on CT scan, what we see, the most important thing is the arterial phase, the early phase. If we see the enhancement, it can be, the heterogeneous. Mostly it becomes heterogeneous, but whenever we find the washout on delayed phase, we can say, the diagnosis of HCC confidently. Even in some cases, we don't need FNAC at all. We can go for the next management. Even in our neighbor countries and India, they are also practicing the same thing. I don't know about US, but I think the imaging is very important for that. But to the HCC from other, the conditions like hemangioma or FNH or the benign conditions like secondaries, we can easily by radiological the characteristic enhancement pattern, we can say confidently that this is not HCC, this is hemangioma, because a lot of cases from the ultrasound, they call it HCC, but later whenever we go for the triphysic CT scan, we diagnose confidently that this is HCC. And another thing is for doing some interventions like TACE or other things, so we need to know the portal vein thrombus. So on CT scan, we can tell it, confidently if there is any thrombus within the portal vein and about the dilatation and the other, the severity of liver disease, like if there is cirrhosis or cirrhotic nodules. These things, we can do it by radiology. So radiology is an important part of, management of HCC, and I think this webinar helps us a lot. And this is a very good initiative, and it will continue in future. And that's all from my side. Thank you very much.
Thank you, Dr. Moin. You made also a good point. Answer to a question about in USA. So there are two primary contrast imaging modality. One is triple phase CT or triphasic, where you do 3-phase. You have a non-contrast phase, you have an arterial phase, and a delayed phase. Because the hepatic cellular cancer carcinoma has only have blood supply from hepatic artery. That's why the imaging is so valuable. And we, in USA, we probably 10 to 20% we do biopsy. About 80 to 90% of the time, we diagnose just based on the imaging. So our most preferable is MRI, and also triple phase CT is as good as MRI, but probably MRI is a little bit better. But we do the same as like other parts of the world. But in USA, it's mostly diagnosed by imaging modality. We only 10 to 20% of the time only do biopsy. And same thing with you have to know there's a portal vein thrombosis, whether it's a bland thrombus, a tumor thrombus, because if you have a tumor thrombus, then it's already advanced. So they probably, local regional therapy may have some role, but not much as so if it's a bland thrombus, which is just a, regular thrombus. So it does give a lot of information about the diagnosis, the staging, and, and based on that, you can decide what treatment patient should go. So thank you for your valuable opinion, Moin. And then lastly, I'll go to not the list, Dr. Atik Rahman, our favorite Atik Bhai. And, he's in Florida. He's largely, with PH as like myself as well. And also, he does take care of a lot of liver cancer patients. So I'd like to hear from him. Atik Bhai, please go ahead.
Thank you so much. Ashraf, you take a great initiative to do this. When I talked to you about the October is that Liver Cancer Awareness Month, we put down all these great faces, the right faces and the most important faces in the field of hepatology in Bangladesh. And I really wanted to thank you all first for coming out. And today, first of all, I would like to thank the two very nice presentation of the cases. Great job. And second of all the speakers here pretty much summarize where we are. At this moment in this world, 300 million people has diagnosis of hepatitis B. They're suffering from hepatitis B. So you can imagine most of them are from the Asian subcontinent, also African sub-Saharan region. So these areas are prone for maximum number of hepatocellular carcinoma. Their third cause of death will be hepatocellular carcinoma. In USA, we have, right now, number one cause of liver transplant is fatty liver. And I can tell you all over the world, very soon, fatty liver will be the single most important cause of hepatocellular carcinoma. So, and as we are talking about it, everybody told the importance of screening of hepatitis B, screening of fatty liver, and follow them on a regular basis is a very, very, very important thing. In USA, we have very good screening programs. And when you see a patient, we have quality indexes. We get paid by quality indexes. And when we see a hepatitis patient or fatty liver patients, we have to do screening on a regular basis. If we don't do, we get hammered for that. We get persecuted for that. So I think it's very important in Bangladeshi perspective what you're doing, and especially vaccinations, early diagnosis is the most important things. Regular screening is very important. That's the main message from these meetings. But beside that, hepatocellular carcinoma is a multi-systemic approach here, as everybody else says. And it's a little different than Bangladesh. In Bangladesh, I commend you because all the hepatologists take a lot of burden on themselves. They are doing the work as a radiologist, they're doing the work as interventional radiologist, they're doing the work as an oncologist. So I commend you for that because the lack of resources. And it's a great model to follow. But we need to train ourselves, obviously, and I see how the main centers of Dhaka is cooperating. The necessity of the imaging, Dr. Moin explained it very well. Obviously MRI, the gadolinium and triple phase CT is still mainstay. Most of the hepatocellular carcinoma, we diagnose only by alpha fetoprotein only. Sometimes the number can tell us it is it's hepatocellular carcinoma. But one thing I would like to tell you that Planetary Health Academia, we are committed to do this kind of programs where we can learn from each other. So I learn from you, and we share our knowledges, and we would like to take it to the next level. So one of the things Ashraf or we can offer is developing a good interventional radiology programs. If you would like to, somebody can come and work with the interventional radiologist here. If you are a hepatologist and if you'd like to see how the interventional radiologist working here with the oncologist and the hepatologist, it will be a good idea to come, and we can accommodate that. So please feel free to contact us. Another things I'd like to tell you all, in February, 24th and 25th February, we will be one of the biggest global healthcare summit in Bangladesh. President of Royal College of Physicians, President of Royal College of Surgeons, President of probably American College of Physicians will be there. There'll be some famous liver transplant surgeon will be there. We already talked to Rabbi as well, who's working hard to develop a transplant program in Bangladesh. But I would say the big fish of hepatology is right here. Everyone is here. I would request you, please join in the summit. I would like to reach to all of you to do a session in our global summit. Would like to do a multi-systemic approach. So not only the hepatologist will be there, we'd like to bring interventional radiologists there. We'd like to bring oncologists there. If I can do a multi-system approach to address this issue. So Ashraf will definitely contact you all, and if we can do a Zoom meeting, that how we can do a good part of that summit with the hepatologist in Bangladesh. So that will be my request to you. We're also doing a case presentation competition during our summit. So the young physician who's doing a great job presenting cases, feel free to contact us very soon. We'll be putting in the social media as well as let all of you know. I'll be very grateful if you all help us to make the summit successful and to work together in future. If there are any questions, feel free to reach me. I would like to thank you all. Dr. Farooq Ahmed, I really like the way you summarize things. I have my utmost respect to Professor all the professors from Bangladesh in various aspects to come, but Salimur Rahman sir, I'm especially very grateful to. I remember 1999, I went to Bangladesh, 2001 when as a GI fellow in New York. Salimur Rahman sir arranged a meeting in IPGMR while I was talking about some interventional cases of post-transplant. So it's always nice to see you all, and always nice to see the great faces. Thank you, Ashraf, once again to do such a great job. Thank you.
Thank you very much. I think
may I have the privilege? May I have the privilege to ask a question to Ashraf Malik Bhai and Atik Bhai? These two cases, what would you do in your setup to manage these cases?
So both cases, so both has cirrhosis and a large cancer, which is intermediate stage. The second one, Professor Farooq mentioned, and the large. So, in intermediate stage, usually we do multimodal therapy. So we do local regional therapy, and there's some emerging data suggests that adding a systemic therapy like immunotherapy may also improve survival. So the systemic therapy, as far as the local regional therapy goes, the TACE, has limitation in the sense that if it is tumor size more than 5 centimeter, because you really have to do, it causes infarction, right? So you kind of embolize the hepatic artery. So there is risk with somebody's cirrhosis, there's a risk of liver failure. So what we do is mostly Y90 with radioembolization. So it doesn't have embolic effect. So you can actually treat a big size tumor. So somebody with a 13 centimeter, 10 centimeter tumor, if you do radioembolization, you don't have the embolic effects. So the patient will have much less risk of side effects, especially hepatic failure. So both cases, we probably would do radioembolization with Y90. So this is something I think, all the interventional hepatologists, maybe they can, see if something can be available in Bangladesh. I don't know if there is a company who, can in India, I'm sure they do it, right? Radioembolization. But you can also do radioembolization along with the TASE. So the patient may get radioembolization first. Usually try to do radioembolization first, and the second session you can do TASE. So both cases, I think they probably need 2 sessions of treatment because it's so large. So it may need 2 sessions of treatment. And then of course, at some point, because the tumor is going to progress, it's so large, it's most likely it's going to progress, may need systemic therapy.
Do you have any experience? Recently, I've gone through some recent articles and I forgot whether it's from Thailand or Hong Kong, I don't know. They have shown that they have done few cases of TASE combined with SBRT in this kind of
Yes.
cases.
Yes.
Yeah.
Yes. SBRT, as you made a good point, actually, we begin to start doing some SBRT. Some are patients who are not, otherwise not a great candidate. It's not because of the tumor, thrombosis. It's just overall their functional status and everything. And we feel that our location of the tumor and all that. So yeah, so most patients do get multimodal therapy. So SBRT, we do TASE. And if the TASE looks, because some tumor may not be responsive, they're not responsive to TASE. So, and if we do a repeat scan after 4 to 6 weeks after the TASE, and if we see still there is residual tumor, and then we go for SBRT. Yeah, SBRT has an emerging role. And we begin to use SBRT in a lot of our patients who are large size tumor.
And what about the use of microwave ablation in this kind of cases? Because is there any role of microwave ablation?
So microwave ablation is good for small size. If somebody, resection, not a resection candidate, if they have a small size tumor, usually, the best response would be less than 3 centimeter, up to 5 centimeter. You can do it if you're, if you're able to target it. But usually it's a small size microwave ablation is the best.
But with the combination apart over SBRT, is there any?
So if let's say if a patient has a 3 centimeter tumor, actually microwave ablation is
this is the standard. This is the standard practice. But if we if you think beyond the boundary, is there any scope
beyond the boundary? No, if it's a large size, probably you won't be able to kind of target a lot of the tumor. So microwave ablation, let's say you do a TASE and you see the residual tumor is left only 4 centimeter left, and you can do microwave for that. Yes. Yeah. So if it is a
a secondary modality in future,
secondary modality.
When you start treating the tumor size, the microablation can be helpful when it shrinks. So
if you have a secondary, if you see the residual tumor is small, and then you can do microablation. So there is no limitation as for which one, whether you can do combination or not. You can do any combination. You can do TASE and Y90. You can do TASE and radiation. And you can do TASE and microwave ablation, and TASE and systemic therapy. Patient can be on systemic therapy and can get radiation too, like immunotherapy. I don't know how much. So about the cost, the immunotherapy, how much is the cost in Bangladesh? I mean, the company, are they like, because I know when we did our internship, they used to have like a free medicine. Is this something the company can provide for some poor patients in Bangladesh? They can offer something.
I don't think so. At least not
right
with
now,
the immunotherapy.
Can I tell about the immunotherapy? So it costs in parts per cycle. It's nearly 4 lakh plus. But as the Roche is giving a benefit that if someone take first therapy, then the second therapy will be free of cost. So atezolizumab and bevacizumab, these 2 combination of drugs we can use, that patient can get 6 cycle with the cost of 3 cycle. So it costs nearly 13 lakh, I think. That is 1,300,000 in Bangladeshi taka.
That's a lot. So at least they're giving some discount in one way, right? So they're giving the second one free. So that's a good thing, because like you said, atezolizumab and bevacizumab they have a good data in some patients, up to 2-year survival, even shows. So how about the other systemic therapy like tyrosine kinase, like lenvatinib, or do they have?
These are used in almost regular basis because TKI are available for couple of years, and But the other regarding other immunotherapy, these are also being used like nivolumab, and still I think that we have to see the follow-up of the patients, that how much it is effective in our populations. But other TKI among this, lenvatinib used a bit more than sorafenib, but still it is costly. Lenvatinib cost nearly 30,000 taka per month. Yeah, 30,000 almost nearly per month, or maybe a bit less from that.
And
Still,
Bangladesh, go ahead. Professor.
30,000 Bangladeshi taka, yes.
And Bangladesh company, pharmaceutical company, make these drugs or Kerala?
Yeah, they are making these drugs. So I'm telling 30,000 maybe a bit later, because it may be like 20 to 25,000 in this amount, I think, the range. And these are produced mainly by Bangladeshi companies right now, lenvatinib and sorafenib.
Oh, this Bangladeshi company. Okay. And they have any discount program, like patients? They have any discount program like immunotherapy, or no?
Oh, no, for immunotherapy, I have already mentioned that they are giving the second cycle free. That is, if first cycle the patient can tolerate and can take this, then they will give the second cycle, and patient will pay for the third cycle. They will give free the fourth cycle, and like this, patient if continue, then he can get sixth cycle.
All right.
We are using nivolumab with lenvatinib in our center.
In your center, okay.
Nivolumab, about 40 milligrams, and this appears to be beneficial because the patients, most of the patients cannot afford silizumab and bevacizumab. So how much you advocate this?
Yeah, I mean, I don't do immunotherapy. Like I said, you guys are like, like a gem. Use, you have experience at everything. Because we're only do general, just managing the liver, cirrhosis patients. And I used to treat with, when all the immunotherapy was not available, I used to treat with sorafenib and lenvatinib. But now the immunotherapies are so good, we just usually refer them to oncology. So our oncology colleague, they do use different combinations. So they use, like you said, the lenvatinib and nivolumab combination, and of course the first choice is always atezolizumab, which is the base data. But they also use other combination immunotherapy. But I really kind of greatly appreciate you guys kind of forefront of everything, treating with the taste, treating with the immunotherapy, and so that's great. It's a lot of credit, for the hepatologists.
Something for the patient.
A lot of credit for the hepatologists. Okay, so I would like to conclude this session. And again, like I think I mentioned, we have a PHS Summit coming up, and we'd like to do a session for that, and we'd like to have a Zoom meeting in the future. And like to have you guys, and we'll be honored to have you guys on that session. So inshallah, hopefully we'll have more discussion about it. Thank you again, all the panelists. And
can I add a point just before you? So
yes.
This is a excellent talk. I think it's already late. I'll not do anything more. So as we know, in US, city command and some state, the mandate, hepatitis C has to be checked in any adult person in US. So I mean, in Bangladesh, we know that Hep B is a big problem, and that highest risk for hepatocellular carcinoma. So is there any, because we have the General Secretary of Bangladesh Hepatology Society, Dr. Shahinul Alam. So maybe that should be a recommendation for all Bangladeshi. At least hepatitis B needs to be checked at least once in a life. So that also is a preventive measure for the deadly disease like hepatocellular carcinoma. Thank you all.
Have a nice session.
Thank you, Khurshid. You made a good point. So yes, something we need to check for each patient. because because hepatitis C also is an important cause, and some may be undiagnosed. So although hepatitis B and fatty liver is the two common cause of chronic liver disease in Bangladesh, but hepatitis C is also has some prevalence in Bangladesh. So something every adult patient should get checked. So thank you again all for all the panelists, all the attendees, the presenter for today's session, and hopefully inshallah we'll have another great session from hepatology.
Okay, thank you very
sir.
much.
Thank you very much.
Thank you. Thank you.
All
Yeah.
right.
Assalamu alaikum.
Alaikum salam.
আতিক ভাই কি আছেন?
Go on.
ফজল ভাই ছাড়া আর কেউ কি আছে নাকি?
হ্যাঁ, আমি হাসিম রাব্বি আছি।
আছে।
হাসিম রাব্বি
আসলে
হাসিম ভালো ভালো কয়েকটা পয়েন্ট অ্যারেঞ্জ করছে।
না আসলে সত্যি কথা বলতে কি আমাদের তো এখন একটা সময় আসছে সবাইকে একসাথে কাজ করতে হবে, আমাদের সিঙ্গেল আমব্রেলা। এই
না,
হেপাটোবিলিয়ারি সার্জারি বলেন, এটা হেপাটোলজি, এটা হচ্ছে কম্বাইনলি কাজ করতে হবে। কারণ আমরা অনেক কিছু যে বিয়ন্ড দ্য বাউন্ডারি করি, হয়তো আমার এটা করা উচিত হয় নাই বা এরকম অনেক সময় আমরা এরকম পাচ্ছি বা আমরাও দেখছি যে আমার ডিসিশনটা হয়তো আপনাদের কারো হেল্প পাইলে হইলো ভালো হইতো, বা আমি এটা টেস্ট করার পরে পরবর্তী চিন্তা করতে পারতাম। এ ধরনের এগুলো যদি আমরা কম্বাইনলি কিছু করতে পারি আমার মনে হয় ভালো হয়।
স্যার হাসিম রাব্বি স্যার, আপনি যে বললেন এই রেডিয়েশন থেরাপি যে এসবিআরটি যেটা, এটা কি স্যার এই এইচসিসি এর ক্ষেত্রে খুব ইফেক্টিভ এরকম কোথাও বলছে স্যার?
হ্যাঁ, এটা নতুন একটা আসতেছে, এটা কম্বাইন্ড উইথ টেইস এন্ড এসবিআরটি। যেখানে টেপ তো সব জায়গায় अवेलेबल না বা এক্সপেন্সিভ।
এসবিআরটি
হংকং না,
মানে এটা তো একটা রেডিয়েশন থেরাপি।
নিউ না, এসবিআরটিটা আসলে বেশ সেভারাল ইয়ার্স ধরে প্র্যাকটিস হচ্ছে। তবে এসবিআরটি নিয়ে একদিকে যেরকম কিছু প্রমিসিং রেজাল্ট আছে, আগের দিকে আবার খুব বেশি এফেক্টিভিটি দেখায় নাই। মানে দুই রকমই স্ট্র্যাটেজি আছে। যে কারণে আমরা এসবিআরটি নিয়ে একবার চিন্তা করি আগাবো, আবার একটু পিছাই, এই চলতেছে।
কিন্তু স্যার আমাদের বেসিকটাই তো ছিল স্যার, এইচসিসি ইজ নট রেডিও সেনসিটিভ টিউমার। এইচসিসি তে রেডিওথেরাপি দিয়ে কোনো কাজ হবে এরকম
ইয়েতে দেয়, প্রোটোটাইন থ্রম্বোসিস এটা রিকমেন্ডেড।
মানে এটা তো শুধু ম্যালিগন্যান্ট,
এখন অনেক আসতেছে, অনেকগুলা স্টাডি আসতেছে।
তবে হ্যাঁ, এটা আমাদের একটু দেখতে হবে। যদি নিউমার্স কোন স্টাডিতে রেজাল্ট ভালো পাওয়া যায়, দেন উই হ্যাভ টু মানে গো থ্রু দিস সিরিয়াসলি।
তবে এটা কিন্তু একদম শেষের দিকের এর জন্য।
ঠিক আছে, সবাইকে দেখা হবে।
থ্যাংক ইউ স্যার।
থ্যাংক ইউ।
আচ্ছা, থ্যাংক ইউ।
থ্যাংক ইউ।